Good afternoon. So we're kind of getting to that time in the day where people, although we did have a really energetic speaker just a little while ago, and so hopefully you guys are all pepped up. So as I was thinking about the title of the slide, I just got off a long haul flight from Nepal today, and I was trying to figure out how I could find joy in a long haul flight, and I really needed that guided meditation. I think. That would have really helped. But it is fortuitous that I came from a healing place, and here I am at this conference speaking today about joy, medicine, and innovation. So, without further ado, doctors, you need to stop acting like yellow cab drivers, and honestly, be more like Uber, Lyft drivers. We won't say Uber because that's not always a good sign these days, but Lyft. So if you think about the prospective yellow cab driver, they spend years saving up to buy their yellow medallion in New York City, right? You all have been in a yellow cab. And once they get their cab, their demand is constant, right? They pick up a passenger, drop a passenger, pick up a passenger, drop a passenger, finish their shift, and then they go home. And that's how it works. Well, visualize the yellow cab experience, right? You get in, and there's a plastic shield, typically between you and the driver. On the passenger side, there's a TV screen and a credit card swiper. And there's very little interaction between you and the driver except to communicate the desired destination and maybe the route you want to go. It's an efficient transaction, but I wouldn't really call it an experience of any sort, right? So contrast that to the Lyft experience. You all have ridden Uber and Lyft in these shared ride-sharing kind of apps. So John Zimmerman, the co-founder of Lyft, wanted to create more humanity and hospitality in the ride-share experience. So when you call a Lyft on your app, and you get into the car, the first thing that happens, it's a clean car, no shield, no barriers, and each of you knows each other's name, right? You greet, so there's a connection right there. You might sit in the front seat next to the driver. That's often encouraged. They may offer you a charger for your iPhone, and some of the Lyft drivers actually have custom playlists to play music that you like from Spotify. So that is a different kind of experience, right? It's an experiential journey, less of a transaction. So that's sort of the theme of today's talk is really evolving from the yellow cab experience in medicine to the Lyft experience, and how we as physicians need to reshift our mindset. So the yellow cab experience is very similar to what goes on day to day in medicine in my view. Right? There's incessant demand. There's never a shortage of patients that we need to take care of. But the problem is, it tends to be a fairly patriarchal system. There are multiple barriers. It's just not always a good experience in medicine. And hence the discussions around burnout and concerns around patient outcomes. If you look at the exam room of today, it really doesn't look any different than it did 22 years ago when I practiced medicine, and probably even 30 plus years ago. It's cold and barren, and it really is not conducive to healing empathic connections, right? If we're thinking about design thinking, we would want to redo not only the physical spaces, but the flow of how patients and doctors interact with each other in the clinic. So the road in this metaphor really represents the external forces that we have very little control over, right? We think about the regulatory, the administrative. There are a lot of forces as physicians that we just don't have control over, and that's the frustrating part. But we do have control over is which vehicle we're going to drive, right? Is it going to be the yellow cab, or is it going to be the Lyft driver? Are you going to have a transactional mindset, or do you want to have an experiential mindset, one of a journey? Um, so that's really the question here. Which vehicle is it that you want to drive? And so what I'd like to do today is to share 3 ideas and 3 patient stories that sort of illustrate the journey I've had over the past 20 plus years as a physician cardiologist, kind of shifting from that yellow cab driver mindset to the lift mindset. And along the way, rediscovering the joy in medical practice with my patients, my team members, and my peers. So I was brainwashed to be a doctor. If any of you were born to Indian parents, that's mom and dad, in the 60s or 70s, you were either going to be a doctor or engineer, right? And so that's how I went. Finished high school, went to college, even went to medical school. It wasn't probably till the first year or so of medical school that I thought, hey, this is not a bad career. Maybe I should continue doing this. And I was at UVA, and I would work on some of the weekends as a monitor tech at UVA Hospital. And so on a Saturday or a Sunday morning, I'd get to see in the CCU the attendings and the residents and the fellows all congregate and do their rounds and interact with the patients. And I thought that was really amazing. And that mind share really kind of rocketed me to keep going in medicine. At that point, I didn't know, I knew I wanted to be a doctor, but beyond that, I had no idea. But the seeds were sown for cardiology at that point for me. In the second year of my residency of internal medicine at VCU, not far away, I did a research in ischemic preconditioning. So it's a way looking at how we can protect the heart when we subject it to ischemia or low flow states, and we were studying rats. And that kind of sealed the deal for cardiology for me, which was really exciting. But I knew that basic research, animal research, was not really how I wanted to create connections. I really needed a human connection, not really a rat connection going forward. I needed a real mission in my career. And that's me finishing medical school at UVA in 1989. So I'm a product of Richmond, Virginia, but I grew up in Hong Kong. I was there from first grade through high school. My father worked for Reynolds Metals, and that's where I grew up. So as a result of living in the Far East, I was exposed to a lot of Eastern traditions, particularly Chinese medicine. And then I'm from India, so we would visit India often in the summers, and I got the benefit of getting deep insights into Ayurveda medicine, the ancient tradition of natural therapeutics that holistically treat the body, mind, and spirit. So all these influences deeply, shaped my thinking. I still pursued Western medicine or allopathic medicine, but these experiences continue to shape how I think about treating patients and the body, mind, and spirit. In addition, when I was at UVA, they have a very strong family medicine program, and the emphasis was treating the whole patient and the whole family. And while I didn't pursue family medicine, and in cardiology, those same values, those same ideas continue to be with me as I practice medicine. So, having said that, ironically, the brutality of medical training, at least when I trained, many when you trained, did not lend itself to creating great healing connections, right? We were trained to make diagnoses, order expensive tests, prescribe medications, and perform surgeries and procedures with little emphasis on lifestyle medicine or even the mind-body connection. So some of you, how many of you remember the book House of God? That's awesome. So that was sort of our Bible, I guess, during our residency. For those of you that don't know the book, it was a satirical, irreverent book about the dehumanization of medical training. And so I remember at VCU as an intern that we viewed our training as a battlefield. That to survive those long, grueling hours, we had to create, humor, kind of sick humor in a way, to be able to get through the day and night. Some of the things that come up out of this book, The House of God, Gomer, Get Out of My ER, hits in the ED. So, and some of these terms we still use today. Age plus BUN equals Lasix dose. And, a good admission is a dead admission. Now, these are obviously cold, impersonal kind of things, but the humor helped us bond together and get through those long call nights. Clearly, it was short on empathy, and that's not something that we learned in medical school at that time or in our medical training. Well, Samuel Shem, a psychiatrist, wrote this book 34 years later. He really started speaking about resisting the inhumanity in medical training. When the House of God first came out 30 plus years ago, he was shunned by lots of deans of medical schools. So he emphasizes two really, really important points that really, I think, flow through the rest of my talk today and the ideas that are in my head. So the first is that connection comes first, and isolation is deadly. So connection really heals. Not only connection with the patients, but connection with each other as peers. And connection is a really, really important thing. If you saw that exam room that I showed you earlier, now we're armed with technology, right, as we take care of patients. And technology can be enabling, but it can also be a barrier. So the EMR, the electronic health record, laptop, computer screen in the exam room now is a barrier. It's a good billing machine. It collects data, but now it puts something between us and the patient, and we lose incredible, important pieces of information that the patients are telling us because we're looking down at a screen and clicking things for meaningless use criteria and other types of quality metrics that are all really box checks. You got that, meaningless use, for those of you. And so one of the things that I've done in the past few years is really leverage the medical scribe. And the medical scribe has completely transformed the way I take care of patients. So no more laptop between me and the patients. I can sit next to Mrs. Jones in the chair. I've already looked at her chart. I come on in. The scribe's in the background to be unseen and unheard, and they're taking in all the history. And I can direct the history. I can talk to the patient, but it's just me and the patient for that period of time. And that's created a ton of satisfaction for the patients, a ton of satisfaction for me because it's more efficient. And at the end of the day, we run a business, and it is much more efficient and productive. You can see a couple, 2 or 3 more people every day because you're not busy clicking away. And so it's a win-win-win to have a medical scribe. So that's one example of how a disconnection can be solved with a very, very simple solution. The second thing that he talks about is learning empathy, right? And a lot of discussion today about that, putting yourself in someone's shoes. So these 2 points really, really are important, but it all starts with listening. And we heard comments about active listening, and so listening is one of the activators of connection and empathy. A lot of times, we're in the exam room and we're time pressured. We want to direct the history. We want to make sure we get to where we need to go, quickly make a plan, and move on to the next patient. But sometimes we don't need to always have to fix or solve a patient's problem, right? Sometimes they just want us to listen, whether it's for 2 minutes or it's 10 minutes. And that listening creates amazing connections and can bring around, and you can get some amazing stories from patients. So the first patient story I'll tell you is someone that I've known for 20 plus years. This is not him. His name is Mr. Robert, okay? And Mr. Robert is 58 years old. He lives in Cambridge He's one of the first patients I met in 1996 when I started practice. And he's morbidly obese, diabetic, high blood pressure. He's got a cardiomyopathy and has chronic heart failure. And he's cruised along all these years with waxing and waning issues. Well, he recently had a infection due to a cardiac device that required explantation. And unfortunately, it became a sort of a chronic, a miserable course for him. He's a truck mechanic, and it really impacted his livelihood. So the burden of managing this chronic disease, not being able to work, really, really wore on him. And he was seeing various colleagues, infectious disease and whatnot. And I had been following his progress through the medical chart, but I hadn't seen him for months. So I asked to have him come to the office so I could just reconnect with him. And I let him vent for 15 minutes, and he was naturally pissed off at the system, the fact that he couldn't work. He was just frustrated, understandably so. So then after he was done with that, we went through some medical stuff, and then I said, what else can I do for you, Mr. Robert? He said, you've done so much for me over the years. What's really, really important is that you care, that you took time to listen to me, and that you're here for me, and I know you're always here for me. And so that was really, really interesting because we didn't really do much medicine in that visit. It was really about connecting, kind of empathizing with the problems that he's had, and knowing that I was always there to guide and navigate him, through this journey that he was having. So the lessons that I learned from this experience go back to trust and empathy. And I realized that these were powerful healing forces. The fact that if you can earn a patient's trust and you can be empathic, that sets the stage for powerful healing to happen in that setting. So many of us, all of us go into medicine for a variety of reasons. I think if we think about, like many of you, I went in, to because of compassion, to quench an intellectual thirst, and to have a good career. But it might be a cliche to say that, but medicine is far more than a career. It's really a calling, and it's a mission. And I firmly, firmly believe that. And if you don't know your why, if you don't know your mission, that can be a challenging. Knowing your why, can help unlock the power of abundance in your work that you do every day. Right? Think about that. So if you know your why, you know your mission, you can unlock the keys to abundance in your practice. And also power through the challenges of day-to-day practice hurdles, right? We have a lot of challenges in medicine today, which I won't get into, but administrative, regulatory, you know the deal. So if you can know why you're doing what you're doing, then that can be transformative. So Sheryl Sandberg, the COO of Facebook, echoed the same sentiments. So she talks about post-traumatic growth. We all hear about post-traumatic disorder, but post-traumatic growth. And I feel like as physicians, we go through a lot of trauma, whether it's in our medical training or just the hassles of everyday practice. So in her book, Option B, which she wrote after her husband died suddenly of a heart attack while they were on vacation, she said, "He who has a why to live for can bear almost any how." So think about that. He has a why, who has a why to live for can power through any how. So that's a very, very important thing, is that to understand your why. Somebody talked about passion earlier. Those are the things that we need to understand. That's one ingredient that we need to talk about. But knowing your why, knowing your mission, is necessary, but not sufficient to create joy in your workplace. Okay, so that takes me to the next idea. So we talked about why and mission and purpose. The next topic is innovation. So, I think that I'm doing a decent job of taking care of patients within the four walls of the hospital and the clinic. But there was something disconnected about this whole experience, right? We're still practicing 911 medicine every day. It's reactive, it's crisis driven. People show up in the ER with an acute condition such as heart failure, and you know well that that more than likely was a preventable condition if we had eyes on that situation, days, weeks, months ahead of time. So, how could we get into the gray space between visits, between the hospitalization and the next clinic visit? So the 99% here represents 99% of a patient's healthcare journey is outside the bricks and mortar. And none of us have visibility in that space. And I said, there's got to be a better way. And this was about 6 or 7 years ago that I began thinking about this. I said, there's got to be an OnStar platform for humans, right? Our cars have better sensors than we do. We take our cars and our pets for maintenance checks, but as humans, we just go to the ER or we go for the annual physicals, which I think are fairly worthless, because if you're looking at one slice of a patient's health with some blood tests, a blood pressure, an EKG, what's going on all the rest of the time, right? Our bodies are talking 24/7, but who's monitoring and managing and who's listening? So I started out, 6 years ago, I joined forces with two tech/entrepreneur kind of guys, and we decided to create a virtual care platform using technology and high touch. So we partnered with a device company that had a sensor that would collect ECG data, activity. It had an accelerometer, so you'd know if they're lying, sitting, or standing, respirations. And we coupled it with a care team that included a nurse, a nutritionist, and a social worker. And we started the program to really look at chronic disease patients, particularly heart failure and post-MI in the transitional care space. So after they'd been hospitalized with these conditions and they went home, we're all being measured on 30-day readmission. So how could we stabilize their care for that period of time or longer without them having come back to the ER prematurely? So we did a pilot study at St. Francis Hospital where I work, and we had about 140 patients that we monitored over 30 to 90 days with heart failure, previous heart attack, and these were a complex cohort of patients, variety of payer mix, age mix, and what we found is that we reduced readmissions at 30 days in this complex cohort of sick patients from a benchmark of 18%, both locally and nationally, down to 4% all cause. And we were just astounded. And it wasn't, the technology was very, very important, but it was the human touch interaction that made it a ton of difference. So we then partnered with the Mayo Clinic and got an NIH-funded trial going to look at this more rigorously, because it's a pilot. Does this really work? Is it scalable? And so the study is ongoing in several Mayo affiliates, outside of Virginia. So we'll see where that goes. But 6 years ago, the opportunity was still not scalable. So one of our patients, Mrs. Mayo, and no relation to the Mayo Clinic, had a heart attack. She was 88 years old, and she made the statement. She said, "I heal faster when I know someone is watching over me." So we had achieved our medical OnStar platform by connecting Mrs. Mayo, connecting with Mrs. Mayo, outside the hospital in the clinic. We learned many things along the way, that medication adherence is only one piece of care management, but that the reasons that people get readmitted to the hospital far, it involves all sorts of psychological, psychosocial, and economic factors, the social determinants of health, if you will, and that it was really about using data in a way that could interface with a high-touch approach, a team-based care approach that could impact care importantly. So meet Miss Jackie. So Miss Jackie was one of our patients that was enrolled in C3. She was a patient of mine as well in the C3 program, and she was a complex patient. She was a dual eligible, she was 60 plus, African American, lived in the city, was labeled a frequent flyer, non-compliant patient, and she had suffered a stroke after heart surgery and then was left with chronic kidney disease and subsequently chronic heart failure. So we engaged with her, and through her nurse, who is my wife Jill, and our social worker, who was my co-founder's wife Grace, they gradually earned her trust, and her medical care stabilized, and she was not readmitted, beyond that, which was amazing. But here was a lady that had limited income. She would make choices on whether to buy food or medicine or pay her rent, and so we were able to change that dynamic just by being able to connect with her. What we learned a lot about her is that in a 15-minute office visit, you don't know what's happening outside that space. But she was a children's author, she was a musician, she was an executive assistant at a major corporation before she got really sick, and now she was this complex care, chronic care lady. So that we learned a lot of lessons there, and again, trust and empathy were consistent forces here that really impacted her care. So while I had the bug to be an entrepreneur, to do more things, you don't need a side hustle to be an innovator, okay? You can be an entrepreneur. There are things within our clinic that need to be solved every day. So think about your clinic, your ER, your OR, your ED, as a living lab of challenges and opportunities that need problem solved every day. So taking on your entrepreneurial hat, solve those problems, and improve care delivery. So I think it's really important for us to really focus on better care experiences, not only for patients, but for physicians as well. One of the things that kind of pees me off is that in big healthcare organizations really focus on patient satisfaction at the expense of employee well-being. And that seems to be reversed, that kind of thinking in healthcare, where in other industries, it's different. Richard Branson, who's the wildly successful entrepreneur, founder of the Virgin Group, says, clients do not come first, employees come first. And if you take care of your employees will take care of their clients. I think that's a powerful statement. Happy employees can make happy patients. So that takes me to my next kind of idea here, and it's about play. So we talked about passion, we talked about innovation, and now I want to talk about play. I do believe that humor and playfulness can create a healing connection, and laughter is the best medicine, right? So in the Hindu tradition, the reality play can be explained by all of reality is considered play. So Leela, which is a Sanskrit term, means pastime, sport, or play. And so Leela is a way to describe all of reality, including the cosmos, as the outcome of divine play. Um, in a more secular way, James Michener, the famous novelist, said, "The master of the art of the living knows little difference between his work and his play, his leisure and his labor." Um, he simply pursues excellence, leaving others to figure out whether it's actually work or play. And to him, he is simply doing both all the time. So many of you have seen this graph. This is the chart that looks at the basic Maslow's basic hierarchy of needs. So I assume all of you have food security and safety under your belt. Some would say in the 21st century, under this, we should have Wi-Fi, and that's a basic need that we all have. But to be able to transcend those basic needs, to attain a higher level of existence, to attain more mastery and imagination, play is the tool that really helps transcend that space. So in the exam room, I really believe that play creates other kinds of healing connections between the patient and the provider that can really impact outcomes. And when I think about play, it's a mindset. We're not talking about necessarily physical play, although that has benefit as well. But when I'm talking about in the medical space, it's a mindset of playfulness and humor. So meet Miss Vera. She's one of my favorite patients of my medical practice. She was in her 90s and early 90s when I first met her. She moved from New York after her husband died to live with her daughter in Richmond. And I stented her LAD when she was 95, and I'm sure there's gasps in the audience. But then she died at the tender age of 103, and from pancreatic cancer. And I looked forward to her every visit. We would talk about our medical stuff for a little bit, and then we would jam about where she and her daughter, who was a travel agent, would go, for their trips and whatever else she would do. And the end of each visit, she would treat me to a dirty joke, and we would laugh and laugh and laugh. So on one of those visits, she was complaining to me about her peripheral edema, and she said, "Doctor, what do I do about this?" And in my typical way, I said, "Well, when you're sitting, prop your legs up, or if you're laying down, put them on some pillows." And she said, "Dr. Kapadia, no man has asked me to elevate my legs in years." And that was one of her cleaner jokes. And so she was a real amazing lady. And I really feel like that laughter contributed to Vera's longevity. But I also feel that the playful connection that we created in that clinic and all those visits helped my career longevity and quality. So, in conclusion, the practice of medicine has many challenges. And I don't need to go through them, but there are many potholes, just keeping that road metaphor going, and many friction points. But there's a silver lining, right? The exponential advancement of science and technology has created a perfect storm for the trifecta of big data, digital health, precision medicine. These are terms that are batted around constantly, to create a new paradigm of P4 medicine. I call it P4 medicine: predictive, preventative, personalized, and participatory. And so I'm excited about that potential future. But how do we reconcile all this big data with the current challenges of big data or big medicine, corporate medicine, with the future state that is hurtling towards us? How do we figure this out? Well, the walls are coming down, right? Healthcare is shifting inexorably from a Blockbusters model to a Netflix on-demand anytime model, right? And you all know what happened to Blockbusters. So if you think about blockbusters as the traditional hospital healthcare model, it's shifting, right? And we need to shift towards that. So how do we do that? So the call to action really for us is to become more elastic as physicians, be more adaptable, less rigid to meet the current challenges around us. Physician 2.0 is empowered and enabled by technology, not hindered or enslaved by it, but also EQ or emotional intelligence is a big piece of this and becomes the most valued asset, more so than IQ and technology. So it is really powering Physician 2.0 with, armed with technology, having EQ, and of course the power of an amazing team, because it is about the team to manage patients through their illness. So how we do this, and we talked about these elements today, is to ignite your curiosity, engage in play, and really find your passion in the things that you're doing. But we have to take care of you in order to take care of the patients. So you've got to ignite your own mind, pay attention to your body, and mind your spirit as well. And we need to take care of each other, because if we do these things, then we're in a position to take care of our patients in a better way. Daniel Pink, do you have a couple more minutes? Okay. So Daniel Pink, who is a prolific writer, said human beings have an innate inner drive to be autonomous, self-determined, and connected to one another. And when that drive is liberated, people achieve more and lead richer lives. So the yellow cab driver will continue to pick up passengers and drop passengers. But the Lyft driver, armed with this sense of humanity and hospitality, will be the one that enjoys the journey. Right? So which do you want to be? For me, it has never been a better time to be a physician, to be in medicine. I think it's a mindset. My daughter, Sonia, who is finishing her first year undergrad at UVA, thinks so too, and she plans to pursue a career in medicine. So thank you very much.